way from New Zealand. Check this out. Asymptomatic annular tear right there and right there. Just like a slit going across. And look at the L4-5 level. It's hyperangulated on those two motions. So there's a little bit of what I call micro instability, putting lots of wear and tear on this disc, and should develop an annular tear that will not heal because it keeps getting irritated. So, went all the way to San Diego School to do a minimally invasive endoscopic discectomy and annuloplasty. Chromatodisc. Oh, look at that annular tear. It's just immediate. Oh my goodness. That's the most prominent annular tear I've seen in a while. Luckily, we've saved all the images because I need to write the Master Techniques chapter in the upcoming ISASS journal devoted to master techniques in spine surgery. Look at that blue dye, because that's the white part of the disc that's normal. It's really firm. Look at how empty that is. That's the empty tent sign. Look at all these extra blood vessels too. And that blue dye really helps me because that might be a nerve. It's not, but it might be. And everything's a nerve or a blood vessel until proven otherwise, because those are the vital structures in there. And we must protect vital structures. And then the next thing is, you can see the protrusion. Everything's stuck to itself. It should be completely free and loose, because the nerve needs to slide almost a centimeter up and down as you straighten your knee out. That's called the straight leg raise test. If you have a big disc herniation, you straighten your leg out like that, it will tug on the nerve. Here's the first landmark, Wagner's Arch, after Ralph Wagner from Germany, one of my heroes and colleagues. Here's the disc. Here's the edge of the pedicle as it rises up and becomes the superior articular process, which is the outside half of the facet joint. And the nerve is over here to my left coming out. That's the exiting nerve root. And up at 12 o'clock, a little bit more inside, is the traversing nerve root and the canal. There's the annular tear right there, way inside there. I wouldn't be surprised if a bunch of pieces start flying out of here. I'm protecting the exiting nerve root and tamponading that one little pesky blood vessel that's impeding my view. And there it is. You can see it going straight up. You can even see the blood vessels right there, look. So this is how you do a discectomy and annuloplasty with the minimum amount of collateral damage, because this is a tiny little poke hole. And when I use this electrical instrument right here, it communicates with the nerve. There's the delamination right there. You poor thing. Pathetic disc. Lost all its structural integrity. I'm going to use this curved pituitary grabber called the curly Q because it curls up. Look at that. There's like a little pocket of trapped nucleus. It's way in the back. And there's a hole right there. Look at that. Oh, look at this. Doesn't look like much, but it doesn't need to be. Woo! Across, X-ray. See the tip over there on the X-ray way back there? Which makes perfect sense, just like I thought. Not to brag, but I love being right, because it means there's kakapupu in here, and we're treating kakapupu. I'm a kakapupu treater. And I don't know if you notice how unbelievable my radiology tech is. Big T right there. He moves that C-arm like an athlete. Okay, all done. Removed all the loose pieces. I treated the edges of the tears to start a new healing reaction. There's areas here on the end plate that's probably pathologic. No more loose pieces. The nerves are all inside here in this fat. I'm going to release that in a second. But that's looking good. Found a lot of bad stuff, so I'm hoping that you get a really good result really, really quickly. Surgery's all done. Look at that cute little poke hole. And you have perfect skin, so I bet you we won't be able to even find this incision in about 3 months. It went perfectly. I found so much bad stuff, so we're all expecting a great result and a speedy recovery, so best wishes.